Mr. Chairman, time's on.
You start. Okay. Welcome to APSC Carl Forum of Cardiovascular Disease Series. I would like to thank Professor Julian Lin to organize this session. I am Dr. Supot C. Mahashota from King Chulalongkorn Memorial Hospital, President of Thai Heart Association, to be chair for the series today. With me, we have Professor Hidehiro Kaneko from Department of Advanced Cardiology, the University of Japan, Tokyo, Japan, will be shared with me. Today, the topic is Cardio-Oncology 2022, Part 2, Clinical Management of Cardiovascular Toxicity in Cancer Therapy. Cardiovascular toxicity in cancer therapy could be life-threatening in debilitated cancer treatment patients. Cardiac dysfunction caused by traditional anthracycline therapy, HERS antagonist, or novel target therapy like a VEGF inhibitor, tyrosine kinase inhibitor, could be subtle but progressive, reversible or irreversible. Vascular toxicity from radiation therapy could be even more catastrophic and long-standing. Hypertension surge in VSP inhibitor therapy and QT prolongation in arsenic therapy could be disastrous unless carefully monitored and managed properly. Venous and less arterial thromboembolism is another threat from cancer-related hypercoagulability, striving for precision management during cancer therapy. Today, we have 6 distinguished speakers to stay with us. If you have any questions, you can write on chat box. I would like to start with Dr. Chung Ju Hua from Singapore. She is a consultant cardiologist at National Heart Center, Singapore. If you address the topic of neurohormonal therapy in prevention and management of incident heart failure in cancer therapy. Please, Dr. Chung.
Thank you. I'll just share my screen. So thank you for the opportunity to present on this topic today. I'll be presenting on neurohormonal therapies in prevention and management of incident heart failure in cancer therapy. There is improved life expectancy for patients with cancer, and it's improving. The cardiotoxic effects of chemotherapy are becoming an important determinant of long-term morbidity and mortality, as cardiotoxicity can both limit oncologic treatment and worsen long-term morbidity and mortality for these patients. Anthracyclines and anti-human epidermal growth factor receptor 2 HER2 agents have classically been recognized as common causes of chemotherapy-related cardiac dysfunction. However, more recently, and with greater use of novel targeted agents, a heterogeneous spectrum of cardiotoxicities can occur due to modern cancer treatments, such as immune checkpoint inhibitors, as well as the newer HER2 monoclonal antibodies, such as pertuzumab, HER2 antibody drug conjugates, TDM1, TDXD, and TKIs, such as tucatinib and lapatinib, in the breast cancer field. Today, we'll be focusing on notable clinical trials that have investigated the effects of pharmacologic interventions in the prevention and treatment of cardiotoxicity manifest as heart failure. The studies included today will predominantly have evaluated patients receiving anthracyclines and trastuzumab because these agents have well-established cardiotoxicity profiles. This figure shows the activation of neurohormonal systems in heart failure. A decreased cardiac output in patients with heart failure with reduced ejection fraction will lead to unloading of high-pressure baroreceptors in the left ventricle, carotid sinus, and aortic arch. This unloading then leads to generation of afferent signals in the central nervous system that in turn lead to activation of the sympathetic nervous system that innervate the heart, kidney, and peripheral vasculature and skeletal muscles. This unloading also leads to afferent signals to the CNS, central nervous system, that stimulate cardioregulatory centers in the brain and stimulate the release of arginine vasopressin from the posterior pituitary. Traditional neurohormonal therapies in heart failure aim to ameliorate this vicious cycle. Heart failure following administration of anthracyclines and anti-HER2 agents such as trastuzumab have been the focus of many studies over the past 2 decades. The two classes of drugs have very different toxicity profiles, where anthracyclines typically cause irreversible myocardial damage and poor long-term outcomes, and trastuzumab effects are usually reversible with cessation of therapy. Many trials have sought to investigate the effects of beta blockers, ACE inhibitors, and ARBs, and mineralocorticoid receptor antagonists. However, there are significant study limitations to be acknowledged. For example, most of these studies are small in number and include short follow-up duration. Many use imaging parameters or biomarkers as primary endpoints rather than clinical outcomes. And comparisons between these studies are limited due to the different types of beta blockers, ACE and ARBs, and different cardiac endpoints used. Overall, the studies show a modest benefit from neurohormonal therapy in prevention of left ventricular ejection fraction reduction. However, the clinical significance also remains unclear. We could put to the audience that it is worth considering whether a higher LVEF in the context of taking vasodilator therapy truly implies cardioprotection. For any given degree of inherent contractility, patients treated with vasodilators such as ACE inhibitor ARBs will have higher LVEF. Therefore, it is unclear if a mildly high LVEF in the treatment arm in these agents means any cardioprotection has actually occurred, rather than the expected small LVEF rise that we would see with active vasodilator therapy. Bit of a busy slide, but I tried to list the main trials using beta blockers. So Kelly et al. Showed that in patients with cancer who are receiving anthracyclines, carvedilol administration prevented decline in LVEF compared to the control cohort. Notably, however, the doxorubicin doses they used were inconsistent with typical dosing strategies, and the carvedilol was actually dosed once daily rather than twice a day. Patients with congestive heart failure, cardiomyopathy, coronary artery disease, or moderate to severe mitral or aortic valve disease were also excluded. These results were then actually not reproduced in the carvedilol effect in preventing chemotherapy-induced cardiotoxicity trial. The CECCY trial randomized 200 patients with HER2-negative breast cancer who were due to receive typical doses of anthracyclines, and they were randomized to either carvedilol therapy or placebo. At follow-up of 6 months, there was no difference in the primary endpoint of significant LVEF decline between the two groups. The PRADA trial, which is the prevention of cardiac dysfunction during adjuvant breast cancer therapy trial, was a 2x2 factorial design randomized control trial of candesartan and metoprolol in women with early breast cancer undergoing therapy with anthracyclines with or without trastuzumab. Metoprolol dose was not associated with attenuation in LVEF reduction. Notably, the LVEF was actually measured by cardiac MRI, and measurements were made by echocardiography in the CECCY trial. The Manticore trial is the trial of multidisciplinary approach in novel therapies in cardio-oncology research. It investigated the effects of beta blockers in trastuzumab-related cardiotoxicity, and 99 patients with breast cancer who received trastuzumab were randomized in a 1-to-1-to-1 fashion to receive perindopril, bisoprolol, or placebo. The majority of these patients, 77%, were actually anthracycline naive. It was found that there was no significant difference between groups in the primary endpoint of LV remodeling, defined as the change in LV and diastolic volume on cardiac MRI. The Glulin et al. Trial randomized 468 patients with HER2-positive breast cancer on trastuzumab to treatment with lisinopril, carvedilol, or placebo. There was no significant difference in the primary endpoint rates of cardiotoxicity. With regards to the use of ACE inhibitor and ARBs, enalapril and candesartan have been studied against placebo in the prevention of chemotherapy-related cardiomyopathy. In survivors of pediatric cancer diagnosed with a cardiac abnormality, enalapril appeared to decrease the left ventricular and systolic wall stress, although it did not improve maximum cardiac index on exercise echocardiography testing. The benefits of enalapril were also evaluated by Cardinale et al. In patients with various cancer types who had troponin elevations shortly following high-dose chemotherapy. Patients who were randomized to receive enalapril following an abnormal troponin level showed a 0% rate of cardiac events compared to 43% in the control group. In contrast, candesartan was not associated with improved cardiac outcomes in patients with breast cancer on trastuzumab therapy in a study by a different group in a cohort of patients who had all previously received anthracyclines. Although the PRADA trial did not report a difference in LVEF in patients treated with metoprolol versus control, it did show a statistically significant attenuation of LVEF decline in patients treated with candesartan compared with placebo. LVEF declined 0.8% compared to 2.6% in the placebo group. However, as already mentioned, the clinical significance of this small absolute difference in LVEF is questionable. The OVERCOME trial, which is the prevention of left ventricular dysfunction with enalapril and carvedilol in patients submitted to intensive chemotherapy for treatment of malignant hematopathies trial, was a randomized controlled study that investigated the effect of treatment with enalapril and carvedilol in preventing changes in LVEF in 90 patients with leukemia or malignant hemopathies undergoing autologous bone marrow transplant. The majority of these patients received anthracyclines as part of their oncologic treatment. Combined therapy with cardioprotective agents prevented LVEF reduction compared to the control group at 6-month follow-up, negative 3.1% difference by echocardiography with a p-value of 0.035. There was, however, no difference in total mortality between the groups. The intervention group had a lower incidence of combined event or death or heart failure. There was no difference in serious adverse events between the two groups. The SCHOLAR trial, which is the safety of continuing chemotherapy in overt left ventricular dysfunction using antibodies to HER2 trial, evaluated cardiac events in 20 patients with breast cancer on trastuzumab therapy who received ACE inhibitors or beta blockers. Notably, all patients included in this study received doxorubicin of trastuzumab of 34 days. So with this approach, 2 patients experienced a cardiac event defined as an LVEF reduction to less than 40% with heart failure symptoms. In the prospective SAFE Heart trial, which is a cardiac safety study in patients with HER2 breast cancer of 31 patients, 90% of patients were able to complete HER2-targeted therapy with cardioprotective medications and close monitoring. All in all, although these data provide some reassurance that mild cardiomyopathy should not necessarily preclude completion of trastuzumab, larger randomized studies are needed to further study the risks. With regards to mineralocorticoid receptor antagonists, they're not as well studied in the cardio-oncology population. One study of 83 patients with breast cancer receiving anthracyclines showed that spironolactone therapy attenuated LVEF decline at 24-week follow-up. The spironolactone cohort changed from 67% to 65.7% versus change in control group of 67.7% to 53.6% in LVEF. One group has tried to summarize all these studies in a meta-analysis, randomized control trials of adult patients who had chemotherapy and neurohormone therapy. These patients were on beta blockers, mineralocorticoid receptor antagonists, or ACE inhibitor ARB. Most of the included studies were of young patients, age range between 38.7 to 52.9 years, and only a majority of patients in these studies had cardiovascular comorbidities such as hypertension and diabetes. Notably, as per the ASCO guidelines, these concomitant cardiovascular comorbidities can actually increase the risk of developing cancer therapy-related cardiomyopathies. Patients treated with neurohormonal therapy had a small but statistically significant attenuation of LVEF reduction by 3.96%. However, the significant heterogeneity among the studies, and this then limits the interpretation of these results. Therefore, unfortunately, the effect of neurohormonal therapy on long-term clinical outcomes of cardio-oncology patients remains unknown. Neurohormonal therapy may attenuate LVEF reduction in patients receiving cardiotoxic chemotherapy. However, these changes appear to be small and short-term follow-up with unclear clinical significance. Carvedilol has been best studied as described, particularly in patients exposed to anthracycline therapy. Metoprolol does not seem to be cardioprotective in patients on anthracyclines with or have been studied, including enalapril, candesartan, and lisinopril. Most of these studies suggest a small attenuation of LVEF reduction. There are not enough data to support the use of one agent over another. Cardioprotective agent medications appear to be well tolerated in the cardio-oncology patient population, and they may decrease chemotherapy interruption, particularly for patients who are receiving trastuzumab. Overall, studies of neurohormonal antagonists for cardioprotection from anthracyclines and or trastuzumab struggle from methodologic challenges, small sample size, heterogeneity from studies, patient populations, and in most cases, small, if any, corticoid receptor antagonists and also statins in the prevention and treatment of cardiotoxicity also need further studies. Lastly, going forward, with increasing recognition and concern regarding chemotherapy-related cardiomorbidity and mortality, there is also increasing collaboration between oncologists and cardiologists to improve clinical trial study designs. This will enable better understanding of cardiovascular toxicity of oncologic treatment. A standardized definition of cardiovascular toxicity that reflects clinically meaningful endpoints is needed to enable comparisons of data across studies. In addition, expanding study inclusion criteria to include patients who are at elevated cardiovascular risk is important because these patients may be most likely to benefit from cardioprotective medications and close monitoring by a cardio-oncologist. At this time, there are 5 major NIH-sponsored oncology-based trials as listed with integrated cardiovascular outcomes that are now underway. So hopefully in the future, new clinical trial designs that allow for complete assessment of both cancer outcomes and cardiovascular toxicity will enable us to improve and optimize. To have a further take on this, I would say that traditional neurohormonal therapies in heart failure have conducted trials, large-scale trials, that have unfortunately systematically excluded cancer patients or patients with active cancer or recent history of cancer from their trial design. It is understandable why they would have done that, presumably because they didn't know the effects of these drugs on cancer, and also that these cancer patients tended, as a result of their chemotherapy regime, to be more unwell and therefore maybe more unlikely to tolerate these heart failure therapies. However, we have now a situation where we don't have large trials that support with good quality evidence the use of these neurohormonal therapies in cancer patients, and I think that's an area of unmet need and an unserved population that we need to, as a group, work towards to designing, large multi-center trials with a large, well-powered trial that can actually definitively answer the questions. So further study of mineralocorticoid receptor antagonists, SGLT2 inhibitors, and other heart failure agents such as ivabradine, sacubitril, valsartan are required, particularly in the oncology population. Thank you.
Thank you, Dr. Chong, for your excellent talk. So it's time for Q&A. Is there any question from the panelists, our panelists? May I ask you some question, Dr. Chong? You think that most of the preclinical, pre-medication neurohormonal almost negative, is right? Almost, yeah.
I understand the question to be that the evidence is not completely robust at the moment. Yes, I mean, from our review of the current literature, and particularly with the meta-analysis that was, I think, recently published in 2019, I mean, it's good effort. I think that these efforts need to continue, but perhaps what we really need is a global collaboration where we do simple trials that answer the question with a few centers that recruit, in high volumes, so that we can actually definitively answer the question as to whether the neurohormonal therapies work well in cancer patients. I guess what's encouraging is that it seems from these trials that the cancer patients seem to be able to tolerate the neurohormonal therapies quite well. I think those were one of the reasons why they were traditionally excluded from the large heart failure outcome trials. So I think going forward, we really need international collaboration. We need large trials specifically in the cancer population.
So far, in your clinical practice, no any medication for neurohormonal pre-treatment, is right? In your clinical practice?
Yeah, I mean, we don't actually use any neurohormonal therapies as prophylaxis. I think currently at our current center, we're basically collecting data. So basically looking retrospectively, for instance, at patients who are on SGLT2 inhibitors for other reasons like type 2 diabetes, we would be collecting data as part of our normal national cancer registries to see if there is an effect, on SGLT2 inhibitors on ameliorating cardiomyopathy. But all this data, as you know, is, I would say, poor quality to a prospective randomized control trial. This is retrospective collection. There are biases inherent within registry work. And to really answer the question in an unbiased fashion, we need prospective, large randomized control trials to answer the question of prophylaxis of other agents, not just SGLT2 inhibitors, but ACE inhibitors, spironolactone, beta blockers in the cancer group.
Thank you. Dr. Shang, please.
Yes, okay. Thank you so much. Really enjoy your talk and nice to see you again. And actually, I think you have a very nice review about the traditional heart failure medicines, but we know that's a great improvement about the medical treatment of a heart failure patient, not only the HIP-REF, but also HIP-PAF. So like you mentioned, the SGLT2 inhibitor. So beyond that, actually, we have some experience about patients, if they have post-cancer therapy, they have profound heart failure, we try to use like ARNI, like antagonist, and actually it gets very nice response. So I think now there's one review, there's one small trial, clinical trial observation articles that's published in ESC heart failure, like I think it's 2 years ago. And it shows that about 30 patients and they received the antagonist, and they also have nice improvement about the myocardial function. So because currently we have ideas about the HIP-REF patient, we use like cocktail, there's different kind of medicines and to get a nice improvement about the myocardial functions. So I just want to know your opinions that if a patient really already have like symptomatic heart failures after the cancer therapies, and what's your recommendations? And so in clinical practice, not for clinical trial, because clinical trial we have to maybe only use one medicines. And so your ideas will be similar to treat as we treat a patient with a hip graft, or will be kind of different if the patient have a cardiotoxicity induced myocardial dysfunction? Thank you.
Oh, thank you so much. That's very interesting. Thank you for sharing with regards to that trial. I think it's very encouraging that there are these, I suppose, smaller trials that have come up with encouraging results. And really, I think the push to definitively answer the questions to have larger, prospective randomized controlled trials in hopefully an international setting. In terms of our clinical practice in patients who have, definite cardiotoxicity by definition, so on echo with a relative change in GLS of 15% or a drop, in 15% of their the actual LVEF accompanied by heart failure symptoms, we would try traditionally the beta blockers and the ACE inhibitors first. We would use this in collaboration with the oncologist because they often like to be involved, especially when we're using ACE inhibitors that can affect potassium and creatinine values and renal function, especially if the patients are having ongoing, very tough, and intensive chemotherapy. So that's what we would usually start off with: beta blocker and ACE inhibitor and ARB, and monitor their renal function, potassium, and blood pressure.
Thank you, Dr. Sean. Do you have any question? If we don't have any more question, maybe we move to the next speaker.
Okay.
Yeah.
So let's move on to the second speaker. The second speaker is Professor Maria Catarina Cruz-Tan from Philippines. She is the Chair, PhD Council on Cardio-Oncology, Head Research Committee, Department of Internal Medicine, St. Luke's BGC from Manila, Philippines. So Professor Maria Catarina Cruz-Tan, could you please start your presentation?
Can you see my slides, sir?
Yes.
Okay, thank you very much. And good afternoon. Thank you for the invitation to do this lecture and for the kind introduction. My topic is on progressive vasculopathy in radiation therapy of cancer patients, surveillance, treatment, and prevention. And right now, I don't have any disclosures. These are my following objectives. I would like to present risk factors that are associated with the development of radiation-induced heart disease. I would also tackle the basic mechanism of vasculopathy and radiation effects. I would also present some clinical scenarios and screening and modern radiotherapy techniques. This journal actually provided a practical approach to diagnosing and management in radiation-associated cardiac disease or radiation-induced heart disease. We know that advances in mediastinal radiation in the past 50 years has contributed to better survival in patients with thoracic and breast malignancy. But several radiation-sensitive malignancies have approximate relationship with the heart. And this would include spectrum of side effects that range from preclinical findings to symptomatic clinical diseases. And more often than not, these manifest decades after treatment and results from diffuse interstitial fibrosis and collagen deposition, along with narrowing of arteries and arterioles. That's why it's very important for us to discuss radiation-associated cardiac disease. And we know that radiation-induced heart disease is a spectrum of deleterious effects that range from pericardial findings to symptomatic clinical diseases that would involve myocardium, the heart valves, coronary arteries, the vascular, even the conduction system. And the effects of radiation therapy would range from preclinical effects, but would also consist of very devastating effects such as fibrosis of the conduction pathway, narrowing, causing CADs and vascular problems, and clinical sequelae would include cardiomyopathy, conduction defects, and a lot of side effects. RIHD, or radiation-induced heart disease, is the unifying term used to describe all of these cardiac complications that are related to radiation therapy. And advancements in cancer therapy have led to improved survival, which in turn has led to increased recognition and prevalence of radiation-induced heart disease. But despite improved RT techniques and modalities, it remains a common cause of morbidity and mortality among cancer survivors. Therefore, prevention, early identification, and prompt treatment are essential in the management. We have radiation-specific risk factors that which include total dose of radiation, mean cardiac dose, frequency of radiation treatments, the proximity of the tumor to the heart, the volume of heart muscle exposed, and the lack of cardiac avoidance technique. Aside from radiation-specific risk factors, we do have patient-specific risk factors such as the treatment at a young age. If patient has traditional cardiovascular risk factors such as hypertension, diabetes, and so on, if there is prior history of cardiovascular diseases, there's also genetic susceptibility and concurrent cardiotoxic chemotherapy. This is a retrospective study that included about 2,000 plus patients with Hodgkin's lymphoma who received radiation therapy. And they found out that a total dose of more than 30 gray resulted in a 3.5-fold higher risk for cardiac death compared to a matched general population. And in another study by Wang et al. From 1996 to 2009, they included about 127 patients with stage 3 non-small cell lung cancer CA. And what they did is to review the radiotherapy plans and cardiac doses, as well as the primary endpoint of symptomatic cardiac events, which include symptomatic pericardial effusion, ACS, pericarditis, significant arrhythmias, and even heart failure. They found out that the overall cumulative incidence of death and symptomatic cardiac events as shown in this figure. And the 2 and 4% 4-year rates of symptomatic cardiac events were 14% and 32%, and this was noted to be increasing with time. The results also showed that in addition to the total radiotherapy dose, mean heart dose and volumes are also independent risk factors for RAHT. And an LV volume receiving more than 5 gray was significantly associated with cardiac events, including symptomatic pericardial effusion, pericarditis, MI, unstable angina, and even heart failure. I would like to go on some pathophysiology of RAHT. The key pathophysiologic step for the development of RAHT is endothelial cell senescence from DNA damage and oxidative stress caused by radiation. Senescent endothelial cells release proteins and pro-inflammatory cytokines, which activate a milieu of subsequent pathways. If we have increased levels of interleukins, tumor necrosis factor, as well as reactive oxygen species, it has been implicated in the subsequent processes. And when we have elevated circulating thrombin, von Willebrand factor, as well as down regulation of thromboembolism, this activates platelet activation. And of course, the associated development of a prothrombotic state. Finally, metabolic and immunologic alterations or activation are noted. And this would include increased glycolysis, altered mitochondrial oxidation, lipid metabolism, and so on. So the product of the above pathway is accelerated atherosclerosis, inflammation, fibrin deposition, thrombosis, and the spectrum of CAD, cardiomyopathy, pericardial diseases, vascular diseases are what we collectively is described as radiation-induced heart disease. So let me present some clinical scenarios. The first clinical case that I would like to present is a patient, a 25-year-old patient with Hodgkin's lymphoma stage 2A, which was diagnosed last 2012, who was in remission. This patient actually underwent 2 cycles of chemotherapy with adriamycin or doxorubicin, bleomycin, vinblastine, and dacarbazine from September to October 2012. And an external beam radiation therapy on the neck and mediastinum was noted. And the radiation therapy was are as follows from November 26 to December 2012. 3 years after radiation, patient presented with anginal pain characterized by intermittent chest heaviness with shortness of breath that radiates to the lower jaw, and this was aggravated by exercise and strenuous activities. Of course, further workups such as a treadmill exercise test showed 1 to 2 millimeter SC segment depression, an abnormal treadmill exercise test. And despite this patient being only 28 years old, this patient underwent angiography, and it was noted that patient had 80% significant stenosis at the mid-segment and even at the osseum of the first diagonal branch. And this patient then subsequently underwent angioplasty of the affected coronary arteries. So another devastating effect of radiation therapy. So this is a clear-cut case of radiation-induced coronary artery disease to a 28-year-old patient wherein intimal proliferation of tissue leads to luminal narrowing, and compared with a patient who is non-radiated, the tunica media is severely destroyed and adventitia is usually markedly thickened and fibrotic. Most commonly affected arteries are the LAD and the RCA in patients who receive mediastinal radiation for Hodgkin's, and narrowing is typically proximal and often involves the ostia. Many potential mechanisms have been hypothesized to explain the development of radiation-induced coronary artery disease, but radiation usually leads to formation of free radicals, which can cause molecular damage. Tissue malfunction ultimately occurs when the cell's ability to repair itself is overwhelmed, and radiation initially causes an endothelial injury in the coronaries that leads to a pro-inflammatory state, which eventually damages blood vessels via oxidative stress, generation of reactive oxygen species, and cytokine release. And this disrupts then the DNA integrity. Of course, the inflammatory cascade that follows leads to ruptured vessel walls, platelet aggregation, thrombosis, and replacement of the damaged coronary intima cells by myofibroblasts. So these changes ultimately accelerate vessel stenosis and atherosclerotic development, leading to CAD in an unusually young patient, such as this patient. Usually, radiation-induced CAD is insidious in onset, often occurring decades after exposure. And the risk is linearly related to the dose, about 7.5% per gray unit. And they usually present with non-anginal chest pain, and this is a common occurrence. Many patients, though, are asymptomatic despite severe proximal diseases, and the presence of conventional risk factors increases the risk further. That's why, as clinicians, we should also address the clinical risk factors of the patient and address this. So the medical management is the same as a non-radiation-induced CAD. Surgical revascularization is a bit complicated because of poor tissue healing, concomitant radiation, lung injury, inadequate bypass targets, and need for compound procedures. There is also higher incidence of graft failure, but percutaneous angioplasty with drug-eluting stent has increased the success rates of initial PCI with bare metal stents in radiation-induced CAD. The second case is of a 77-year-old female, hypertensive with mucoepidermoid carcinoma diagnosed 14 years ago. She was given platinum-containing chemotherapy. She underwent left parotidectomy and had radiation therapy on the neck. But this patient was noted to have a carotid duplex scan with a total occlusion of the left proximal to distal internal carotid artery. There was also significant stenosis in the right vertebral artery. Again, another side effect of radiation, which lead to a significant occlusion of the vasculature. This arteriography was lifted from a study done by Trojanowski et al. And this is an arteriography of a patient, a 63-year-old male, 52 months after laryngeal cancer resection and radiation therapy. And we know that this patient shows severe stenosis and ulceration in the middle segment as shown in the black arrows. And particularly this patient underwent a successful stent placement in the common carotid artery. So treatment-wise, we can also give these kinds of management for our patients. Another study retrospectively analyzed 26 patients who underwent surgery and subsequent cervical radiotherapy for head and neck squamous cell carcinoma, which focused on radiation-induced vascular diseases in the neck arteries. So they observed the latency period to the occurrence of neurological events and succeeding endovascular treatment of the internal carotid artery and of the common carotid artery. Based on these studies, they noted that it is actually common to see these carotid artery lesions after radiation of the neck. So there were about 85% of the patients who presented with internal carotid artery lesions, and succeeding patients also presented with different lesions on different areas. And the number of affected arteries in an individual patient did not even correlate with the patient's age or the time interval from radiation therapy. That's why, as part of management, I believe that we should also do carotid duplex scanning for patients who have irradiated head and neck carcinomas. The wall of the carotid artery consists of 3 layers: the intima, the media, and adventitia. And the intima lies in their innermost layer and is formed of endothelial cells and internal elastic lamina. The middle layer, which is the media, is composed of smooth muscle cells, and the outermost layer, the adventitia, which contains connective tissue. Actually, the exact pathogenesis of radiation-induced carotid artery disease is still unclear, but it can be because of endothelial dysfunction, injury and occlusion of the vasovasorum, and even accelerated atherosclerosis. Let me present the last case, a 55-year-old female, known hypertensive, who was diagnosed with invasive ductal CA, HER2 positive. She underwent radical mastectomy and also underwent chemotherapy, anthracycline based, and even with trastuzumab. She had 6 weeks radiation, and right now she has no evidence of disease. So this patient was actually diagnosed last 2014. And upon checking her 2D echo, we noted an aortic stenosis. The estimated aortic valve area was 0.8 to a 55-year-old, and even the mitral valve here is severely calcified. So another devastating side effect of radiation to a relatively young patient. Valvular heart disease after radiation therapy has an incidence of about 7 to 39% at 10 years and 12 to 60% in 20 years. It most commonly affects the mitral and aortic valves and is characterized by valve thickening and calcification, which may be more extensive and affects more valves. And the surrounding structures may be affected, the annulus and subvalvular apparatus. And the hallmark of a previous heart irradiation is the aortomitral curtain thickening and calcification. And this usually becomes symptomatic later than CAD. So this patient then underwent a successful transcatheter aortic valve replacement. If you have prior chest radiation, it may introduce, though, various technical problems, especially for patients who will undergo open aortic valve replacement. And radiation-induced fibrosis may also affect neighboring tissues and cause adhesions. That's why it's very, this is an important topic for us to know as clinicians, because at least we could address this with the heart team. So the echo features of radiation-induced valvular disease, we know that there is uniform valvular thickening from fibrosis. Usually left-sided valves are affected more than right-sided valves. There is aortomitral curtain thickening, as I mentioned. Regurgitation is noted prior stenosis, and preservation of commissural features are noted. So these are some of the clinical scenarios that we actually saw in our own institution. But of course, clinical manifestations of radiation-induced heart disease is very vast, ranging again from pericardial, conduction problems, and so on. And as clinicians, we have to at least get a good grasp of these complications, know the history of the patient, so at least we could, as a team, discuss the management for these special group of population. So let us go to screening. Patients who have undergone radiation should be screened and aggressively treated for cardiovascular risk factors such as smoking, inactivity, dyslipidemia, diabetes. And some societies have proposed guidelines in the screening of radiation-induced cardiovascular disease. So they would recommend, of course, transthoracic echo, CMR, or CT coronary angiography. But then if there are patients who have new cardiac symptoms, this should warrant investigation right away. Hence, cardiovascular disease should be screened for diligently and accordingly to current guidelines in patients that have received radiation. The screening, of course, would involve 2D echo. It is the main tool in the diagnosis and surveillance. Usually, I already mentioned some of the findings that we can see. biventricular systolic and diastolic dysfunction, involvement of the valve should be screened. And of course, for cardiac CT scans, for evaluation of aortic, valvular, pericardial calcifications, and even peri-procedural planning in transaortic catheter replacement. Of course, for CMR, this has paucity of data, but it actually would provide additional structural and functional information. Of course, coronary calcium scoring is also a useful tool for detection of preclinical atherosclerosis. And of course, single photon emission CT, MPI. It has been used in some studies as a tool, especially for asymptomatic patients. And also, I would like to include carotid artery duplex scanning for patients who have radiation therapy on the neck. And these are the recommended screening for patients who had radiation-induced CAD. Of course, when you have anterior or left chest radiation, these are risk factors, as well as lack of shielding from previous radiation. If there are high dose radiation of more than 30 gray and pre-existing risk factors, we should assess these patients promptly, and whether or not they have signs or symptoms of cardiovascular disease, we have to do screening. And of course, if the screening exercise test or a coronary calcium scoring is abnormal, then we could proceed with coronary angiography. On modern radiotherapy techniques, there are 3 techniques that we use usually. First is to reduce the radiation dose. It is well recognized that the mean dose of radiation to the heart is a significant predictor of cardiovascular disease. There is a linear increased risk of coronary artery disease with increasing mean heart radiation dose. And apart from this, we should also have we have to know that reducing the radiation field and volume is one of the modern radiation therapy technique. Aside from apart from doing an extended field radiation therapy, mantle field, new techniques such as involved node and involved site radiation therapy are now being employed. And we have to employ newer planning and delivery systems such as involved site and involved node radiation therapy based on CT tomography, and newer techniques such as intensity modulated radiation therapy, proton beam therapy have resulted in further improvements. And of course, respiratory motion management, which includes deep inspiration breath holding and end inspiration breath holding, have decreased radiation dose to the heart in patients undergoing mediastinal radiation. So in summary, I discussed some clinical manifestations in some cases of radiation-induced cardiovascular disease. We tackled on the risk factors, as well as screening and some of the management in these particularly important group of patients. Thank you very much for your kind invitation and for listening to my lecture.
Dr. Tan, thank you very much for the wonderful talk and the detailed review of the radiation-induced heart disease. In Japan, radiation-induced heart disease is not so common, but sometimes it is cause severe heart disease and very difficult to treat. So I think that it is very important concept, and that we need to overcome this fear. So my question is, what can I do to prevent the radiation-induced heart disease? Of course, as you mentioned, the reduced total radiation or mean radiation dose is the most important. But for example, considering that the inflammation induced by the heart beam radiation would play a central role in the development of the radiation-induced heart disease. So statin would be beneficial to prevent such disease, because statin could attenuate inflammation in the heart vessel or myocardium. So what do you think of that?
Okay, so I think we are more or less clinicians here and cardiologists. And the topic of radiation is actually not our, it's not our subspecialty. That's why, number one, it's very important to have a cardio-oncology team that would also include the radiation oncologist, because this is not really very known to us. Usually, we only see these patients once they have these problems, and they would only refer to us. But as clinicians, I really feel that we should start with the basic. We should start with prevention. Our tendency is just to treat these patients, but knowing the clinical problems before they start would be important, like screening for diabetes, so checking for fasting blood sugar, checking for cholesterol, and addressing these problems early on, checking for obesity and smoking cessation. These are the things that we could actually help the patient, because as we know, specific risk factors are also include preclinical problems. So we have to center our focus more on prevention for now. And the problem now is that we are seeing these patients, especially for pediatric patients who had pediatric cancers and going to an adult phase. That's why the usual manifestations that we see are already late stage. And like you, Professor, we also see these patients not so often. It's not really common for us to see these patients because usually they already have overt diseases after that. And especially for elderly patients, we don't even know if it's really an effect of the radiation or not. But I think overall, we should really screen these patients and have a good grasp of the history.
Thank you. And so my second and last question is maybe you introduce in your case presentation, you introduce one patient undergoing the TAVI,
Yes.
was aortic stenosis after radiation-induced heart disease. I think that it is very important. And are there any data regarding the safety or effectiveness of TAVI for patients with sufferings from aortic stenosis induced by the radiation? Are there any data?
I've seen some case reports and case series about it, and like what I mentioned, I think it is moderately safer to do. The question now is because some patients are very young, like a 55-year-old, and give that. But in this case, together with the heart team, they found out that the chest was already a hostile chest, meaning because of the prior radiation, they already have a lot of adhesions. And it's going to be more difficult to do an open surgery. So I think it's an option. But with large data, we still don't have that. We have a lot of case reports out there on transaortic valve implantation and cancer.
Thank you very much.
The problem is, but the problem is the TAVI and then TAVI and TAVI. Because the longevity of the TAVI valve is not so long. Yeah.
Yes.
That's the problem.
Yes, I agree with you. That's why it's really important to discuss this with the cardio-oncology team and the heart team. And this has always been a good topic when it comes to having these sessions, intervention as well.
Okay, thank you. And Dr. Shang, do you have any question?
Thank you, and really enjoy your talk, especially special cases. And actually, the TSOC, the Taiwan Society of Cardiology, we have published the one article. It's a consensus with the ASTRO. ASTRO is a radiotherapy society in Taiwan, but we're still struggling with the protocol. Like, how long to follow these patients? And you show that's one scenario. Possibly we can follow every 5 years, but I think after 5 years we have completed all the anti-cancer therapies, so it's kind of a little bit late. But so our radiotherapy, people they try to use like active breath holding, so the patient when they have radiotherapies, they can hold their breath, and we can try to make the breast cancer be far away from the radiant beam. So it's kind of more effective to do protection. But I think beyond the radiotherapy strategies, and sort of still have some pharmacological prevention regimens. Like some articles will say that has a desiderium or the other kind of medicines, and possibly will protect statin or ACI, these kind of things. And so I just wondering your ideas that is it possible we can use these kind of preventive strategies for this patient if they are going to receive radiotherapy? Thank you.
Thank you for that question. I think it's very important to know that dealing with this patient, of course, radiation is not only the risk factor. You have cancer patient, of course, they will undergo chemotherapy. And if that chemotherapy is anthracycline based or anything that is directly cardiotoxic, we already have an idea that we have to screen these patients more often. Like for anthracycline, if the patient has ongoing chemotherapy, we have to screen them every 3 months, or for trastuzumab every 3 months. And the role of cardioprotection, of course, is still debatable. And like what the first lecturer mentioned, there are small data that would provide us with a good study, but overall, there is still no robust study that would provide us with this, or even a study that has a good clinical endpoint, because most of the studies would only give us a change in ejection fraction. But does this translate to a clinical improvement? We still don't know yet. I agree with you that apart from breath holding and other maneuvers for radiation, we still have to give these patients at least a little bit of cardioprotective strategies. That's what I've been doing with my own patients. And so far, we were able to manage these patients well, with the knowledge that we are giving just a little bit, not to cause any hemodynamic problems. So thank you for that.
Thank you so much.
Thank you. So may I move on to the third speaker? Professor Support, could you please introduce next speaker?
Thank you. The third speaker will be Dr. Kisra Buchikan. He is an associate professor of medicine, division of hematology, Chulalongkorn University, Bangkok, from Thailand. He will address the topic of life-threatening cytokine release syndrome in chimeric antigen receptor or CAR T-cell therapy for refractory hematologic malignancy, the role of cardiovascular risk stratification. Please, Dr. Kisra.
Okay. Do you see my slide?
Of course.
Okay. Thank you. Good morning and afternoon, everyone. First of all, I would like to thank the Asian Pacific Society of Cardiology and Thai Heart Association for giving me the opportunity to join the webinar today. I will share syndrome in chimeric antigen receptor T-cell therapy for hematologic malignancy, cardiovascular toxicity, and role of risk stratification. And I do not have any conflict of interest to disclose. And this is the outline of my talk today. I will show you a case, and then I will go back and forth between the case and the topic that we will discuss today. We have a 61-year-old lymphoma diagnosed in 2005. He was treated with 6 cycles of R-CHOP, and he achieved complete remission. And the initial plan was to give him salvage chemotherapy and then proceed with autologous stem cell transplantation. However, he did not respond to salvage chemotherapy. So the plan at that time, salvage chemotherapy, and then we'll plan to do CD19 CAR T-cell therapy. Again, he did not respond to second-line salvage chemotherapy. So the final decision was to just go ahead and give him CD19 CAR T. Brief overview what chimeric antigen receptor T-cell is, just because it's quite a novel therapy, especially in Asian country. Chimeric antigen receptor T-cell is an engineered T-cell which is trans or CAR. The figure on the left side of this slide shows the structure of CAR, which is composed of 3 different domains. The ectodomain, which is derived from the molecule of immunoglobulin, the transmembrane domain, and the CD3 endodomain, which is derived from the molecular side, show you the function and how CAR T-cell work. CAR can bind directly to antigen of interest on the surface of tumor cell in the M of tumor cell. This slide gives you an idea about the manufacturing process of CAR T cells, starting from collecting T cell from activate those T cell, transduce those T cell to express CAR, and expand CAR T cell before giving to the patients. The success of patients' diagnosis of chronic lymphocytic leukemia before moving to patients with B cell, and that leads to explosion of CAR T cell research, and it has become standard of care for patients with relapsed refractory B lymphoid malignancy over the past recent year. Currently, we have 2 major types of CAR T cell, which is approved for patients with relapsed refractory B non-Hodgkin lymphoma and B acute lymphoblastic leukemia. And the other one is BCMA CAR T cell, which is used for patients. Just to give you a little bit more information about what and how CAR T cells work. Once we give CAR T cells to the patient, surface antigen, and in this case today is CD19 on the surface of lymphoma cell. lead to the activation of CAR T cell and also normal T lymphocyte and bystander immune cell. These immune cells will result in release of inflammatory cytokine, which leads to tumor cell eradication. Get back to our patient, just a little bit more information. Then he was diagnosed with a total dose of anthracycline, approximately radiation treatment at that time. Also, he does not have any cardiac underlying history, no dyslipidemia, or give him CAR T cell therapy. The pre-CAR T cell screening workup include normal EKG and normal echocardiogram as defined by normal ejection. The pre-CAR T PET CT scan confirmed massive disease burden in his abdominal cavity of CAR T cell. CAR T cell also carries several unique side effects, especially immune-mediated complication from the inflammatory cytokine, which include cytokine release syndrome, and neurological toxicity include various systemic organ toxicity, hypogammaglobulinemia, cytopenia in infection. What is cytokine release event? This is result from supraphysiologic immune activation, mainly the inflammatory cytokine. This result in a cascade of hypoxia and hypertension. Patients with lower grade CRS has just only fever, so has hypotension and hypoxia besides fever. This slide summarizes, you can see that CRS tend to occur early after CAR T cell infusion with the median onset of approximately 2 days. And the duration, this can be differ among patients depend upon several factors. The treatment of CRS depend upon grade CRS usually require only supportive treatment, for example, antipyretic to decrease the higher grade CRS would require ICU monitoring and intensive supportive treatment, including multiple vasopressor and oxygenation support, and sometimes positive pressure therapy, which include anti-IL-6 and systemic corticosteroid. We may consider anti-cytokine therapies with comorbidities or patients with advanced age. So our patients, when he developed fever on day +6, he also developed hypotension, but still respond to IV fluid. You also on day +7, he again was hypotensive, but this time did not respond to IV. Started on vasopressor. Tocilizumab and dexamethasone was initiated. You can see that CRS can affect the vascular system, which will be a focus of our talk later on today. This study is a real-world study from a report various organ toxicity seen in patients who receive CD19 CAR T. Severe cardiovascular complication could be seen in approximately 50% of the patients. And for grade 3 or more severe, we can see in approximately 20% of patients who receive CD19. Worse, on day +8, he became more hypotensive and required multiple vasopressor. Despite that, he received tocilizumab and high-dose systemic corticosteroid. On day +9, he was intubated. He also had acute renal failure and severe acidosis. Due to persistent hypotension, troponin was checked and it was elevated. Echocardiogram was done and showed decreased ejection fraction of 35 to 40%. This is that I could not upload the video, but it also showed that he had some pericardial effusion. On day +10, he continued to get worse. Day +11, he developed STT change on EKG. And finally, day +11, before the patient developed cardiac arrest and passed away. So immunotherapy and the focus of our talk today, the CAR T cell therapy could cause cardiovascular mechanism, which is the important mechanism is through the inflammatory cytokine as a part of cytokine release, inflammation and tissue injury. The second mechanism, which is the direct toxicity of CAR T cell against cardiovascular on target of tumor phenomenon. And the presentation of cardiovascular toxicity, cardiac injury, arrhythmia, myocardial injury, pulmonary edema, or vascular damage. There are several studies that report cardiovascular complications in patients who receive the prospective study that describe cardiovascular complication in this patient. You can see various presentation of cardiovascular complications, tachycardia, and also cardiac arrest, with summarize various retrospective studies that describe cardiovascular complications in this patient. And again, with various presentation, overall, the cardiovascular events could be 20%. And it can be LV systolic dysfunction, arrhythmia, acute coronary syndrome, and cardiac arrest. When we are talking, we can divide risk factor into either CAR T cell associated or patient associated factor. In terms of patient cardiovascular specific risk factor, the previous cardiovascular disease, previous cardiovascular risk factor, previous cardiac biomarker, and previous cardiotoxic cancer treatment, all of which could toxicities. The box on the right side of this slide are the tools that we have to use screen the patients and monitor the patients who develop cardiovascular complications after CAR T cell therapy. Currently, most CAR T cell center and experts recommend to implement these patients who are candidates of CAR T cell therapy. Patients who have this underlying disorder should undergo for cardiac clearance before proceeding with CAR T cell infusion. And as you already know better than me, if patient receiving the case that we discussed today with the CAR T cell, patients could develop damage to their cardiovascular system, which can divide into two. And cardiovascular risk factor that the patients have, cancer therapy, and the intervention that we give to the patient, eventually this determine which type of cardiovascular damage the patient would have. If you remember the table that I showed you earlier, case related to CAR T cell therapy in various presentations, ranging from arrhythmia and cardiac arrest. Recently, most studies try to focus on major acute cardiac events or MACE. This include cardiovascular death, heart failure, ACS, and this study report MACE in patients who receive CD19 CAR T cell therapy. They observing 22 heart failure, 14 arrhythmia, 2 ACS, and 2 cardiovascular death. The MACE and the incidence of MACE at day 30 was 17%. As were risk factor of MACE occurrence in this study. Studies also try to examine which biomarker we can use to predict. Study observed 17 cardiovascular events in 137 patients. The median time to MACE was 21%. And you can appreciate that most MACE occurs in and have troponin elevation. So the authors who have underlying CV disorder or patients who develop CRS grade 2 or more severe. In terms of late effect therapy, this study described 6 patients from 52 patients who developed LV systolic dysfunction as depicted by the red line, covered their ejection fraction, but some of the patients would require more than 1 month or up to 3 months. Another interesting point, 4 out of 6 patients had elevated, properly screen and treat the patients who develop cardiovascular toxicity. There is a multi-center study that toxicity compared to no cardiac toxicity after CAR T cell therapy. So currently, most guidelines recommend to closely monitor the patient with anti-cytokine therapy in patients who develop CRS grade 2 or more severe. This slide shows a global summary about what we should do to the patients in terms of CRS risk stratification and general risk stratification. And these are some of the work up the criteria that the patient should undergo cardio-oncology consult, grade 2 CRS or more severe, or develop cardiovascular events, and how to follow up this patient. In conclusion, cardiovascular complications are common in this patient, either as a part of CRS or direct toxicity. And this cardiovascular complication could result in life-threatening events or long-term cardiac damage. Currently, how to screen, monitor, manage, and follow up this patient. I could thank my colleague at Cardio-Oncology University, my mentor and collaborator. Happy to take any questions.
Thank you, Dr. Kisada. Very, very interesting topic. Yeah. Is there any question from our panel? Okay, Dr. Sean.
Thanks, you. Nice
It's-
talk. It's
yeah.
very interesting. I just wondering that since that immune checkpoint inhibitor also cause like cytokine release syndrome or like myocarditis. So is there any kind of difference between the CAR-T therapies induced cardiovascular dysfunction and also the immune checkpoint induced? No. Yeah.
For CAR T cell therapy, I mean, there is not a whole lot of evidence, so we just start learning about cardiovascular complication. If you look at the literature, most of them would report, study after 2019 or 2020. So we're still learning about this kind of complication. But like in other types of immunotherapy, like a checkpoint inhibitor, we usually see more like with myocarditis, and sometimes like with the arrhythmia. But most of the CAR T cell associated cardiovascular complication that we see usually is a part of CRS syndrome. So usually what we see a lot is like hypertension and congestive heart failure. We do see some like arrhythmia, but most of the time it's like a physiologic response to cytokine release syndrome, like tachycardia. We do see some tachyarrhythmia, but otherwise myocarditis or like AV block, those kind of things we don't normally see.
Thank you.
Dr. Krishna, can we upfront treatment with the anti-cytokine before we start the CAR T cell? Is this possible, or it's not necessary?
Actually, it's a very interesting question, and there are several trials trying to preemptively treat cytokine release syndrome in order to prevent severe cytokine release syndrome. And I think hopefully will prevent patients from developing severe organ toxicity. But currently it is still under the clinical trial setting. It is not yet the standard of care. But there are several studies trying to give like tocilizumab and steroid early on before develop severe cytokine release syndrome.
Very interesting. Yeah. Thank you. Is there any question? Yeah. Dr. Hiro, you have any question?
No.
No. Okay. Thank you. Okay.
Thank you.
Yeah. Thank you, Dr. Kisda. So we move on to the fourth speaker. Please,
Okay.
Dr. Hiro.
Yeah. So let's move on to the next speaker. Next speaker is Professor Wai-Tin Shang from Taiwan, attending physician department cardiology, Chinmay Medical Center, associate professor department biotechnology, Southern Taiwan University of Science and Technology, Taiwan. The title of her presentation is Venous and arterial thromboembolism in cancer patients, timing and duration of drug therapy. Professor Wai-Tin Shang, could you please start your presentation?
Thank you so much. It's my honor to present, to attend this very meaningful this webinar again. And so today my topic is about the venous and arterial thromboembolism in cancer patients. I think this is also associated with the therapies, like how we treat this patient with anticoagulation. So first, I want to start with the case. I think it's not very uncommon for us to treat a patient with the vascular complication, especially like venous thrombosis in cancer patients. So this is a 38 years old male and a woman, and so she didn't have any kind of medical histories, but she's obesity. And so this time she just received one uterine polypectomy, but she suffered from acute right lower limb swelling for 2 days. So she received the warfarin treatment, but the edema progressed and still had a very painful situation. So also she had like a dyspnea and oropnea. So this is a chest X-ray, and we can see that's clear cardiomegaly, and also the ECG shows signs of tachycardia. So we do the CT scan, and we found that's a significant venous thrombosis at the right limb. And also we do found that there's a significant residual here, and it has external compression to the venous. So the compromised venous return caused the thrombosis formation. So we did the PTA, and the angiography shows that this is a lot of collaterals, but there's significant occlusions of the venous flow to expand the venous. But actually we can see that even we get some flows, but it's not very optimal. So we also do the catheter-directed thrombectomies, and we do the continuous thrombolysis in anticoagulation therapies. And here, her swelling improved, but we still can see some occlusions about the pelvic area. And also because the dyspnea, so we perform the echocardiography, and we can see clear, even the myocardial function is pretty okay, but there's significant pericardial effusions. And so we do the under alternative flow. So it's kind of impending cardiotemporal node. So should you see the pericardial stenosis, because once patient have deep vein thrombosis, it's very high risk to have pulmonary embolism. And so not surprising that we also see that the right pulmonary trunk, there's a significant filling defect. This is pulmonary embolism. So the following story that we also check some like a hematology profile, this protein C, protein out, anti-protein 3. So this is very possible. This is thrombosis is cancer associated. And so about the using polyp, and the pathology shows it's a poorly differentiated carcinoma with multiple metastases of therapy. But I think that's one thing. That's why kind of these kind of things will happen. And let's go back to the pathophysiologies. It's a virtual trial that is a thing that mainly contribute to the venous thrombosis. Patients, maybe they are kind of weakness, and she, like this patient, most of the time she's lying on the bed, so have some kind of static flow about the venous system. And also the cancer itself have contributed to the some kinds of inhibitors of like hormone therapies, and they also will induce this kind of phenomenon. So about the cancer itself, actually the tumor cells, it can produce a lot of tissue factors, and also it which make the fibrolysis and pathological fibrinolysis will have the will decrease about dysfunction. So all these things will contribute to the easy formation of blood clots. So the hypercoagulation situation will, but once these patients have the thromboembolic event, it will be the second leading cause of death in these cancer patients. Like most patients will die of cancer progression, but there's still about 13% of patients will die of thromboembolic. The other thing is about the treatment, the off-target effect of tyrosine kinase inhibitors, because some like these kind of tyrosine kinase inhibitors will also have overlap with the endothelial cell receptors. So it is very possible these kind of things will also contribute to the formation. But once we go back to the guideline, like the two most well-known, the NCCN and ASCO guidelines, and how this guideline recommended us to treat this patient. So like both of these guidelines mention about the treatment of the even risk stratification. So let's I want to introduce two major risk score. And the first of all is the coronary risk score. So like if the patient have the GI tract or like GU tract cancers, it will have 2 points. And if the patient also have like thrombocytosis or anemia or leukocytosis, they also have a contribution, very high BMI like obesity. And this is also will be possible risk factor and to make the cancer-associated thrombosis. And the other is the ultra-wide score, but it's kind of this score states that if the patient have lung cancer, breast cancers, and they will have a higher risk to have venous thrombosis. But currently, the most people use the score is the coronary score. Okay. Biomarker. So in addition to D-dimers, and some articles also suggested osteothrombosis. Okay. So, but now we can do like early detection, but what about the treatment? So in the previous, we found that so if the cancer patient, once they have venous thrombosis event, it will have cause a higher mortality and comorbidities, especially about the bleeding tendency. So previously we used the Taiwan database when we do articles, and we found that once this patient have venous thrombosis, and we will have a higher risk to have mortality and major cardiovascular events following up. So the other things is about the treatment. Like in the past, most of the oncologists, they would like to use low molecular heparins or like use coumadin to treat this patient. Even though that we know that low molecular heparins have effective in this patient, but the adherence is kind of poor. Like this patient have to receive like subcutaneous injection like once or like twice a day. Is very suffering. So if we want to shift to the oral medicines, and one choice is about the coumadin. But the coumadin actually is not very effective in this patient. So now today we have the novel types of to compare with the low molecular heparin and the coumadin. So we will have a different kind of NOAC. So I'll just go back to the major trials about this NOAC, and they just do the subgroup analysis and to collect the data if the patient also have an underlying cancer. And they found that if the patient treated with NOAC and compared with coumadins, this shows a very kind of like effective to treat this patient. But we are not very satisfied with the subgroup analysis. We need a randomized control study. So the first one we had to introduce the Hokusai study, and so they compare the heparin with the idoxaban 60 milligrams, and to see if the patient with active cancer and cancer-associated venous thrombosis and how effective of the idoxaban. And we also know that about the primary outcomes, and the idoxaban can be very effective to reduce the recurrent venous thrombosis, but something that we had to pair with is the major bleeding increased. So following we have the SELECT-D study, and so it compared the heparin or the rivaroxaban, and we found that the rivaroxaban can also effective to reduce the recurrence of the venous thrombosis at 6 months. And something that's exciting is about that even the bleeding tendency, the major bleeding and even like the fatal bleedings will be reduced compared with the heparin. And later on, we also have epizotin. Epizotin have the Cardio studies, and Cardio studies similarly also found that be effective to reduce the recurrent venous thrombosis, and but the measure breathing is kind of similar compared with the delparen. Okay, so we want to know, okay, now we have NOAC, so we can treat this patient with NOAC, but not yet the end of the story. So about our patients, we treated with NOAC, and after precardial synthesis, and her condition improved, and the edema improved, but so something happened. That's not surprising. The major GI bleedings and with anemia. So we have to stop our medicines about the anticoagulants. So the other things we want to know is like how long should we treat with this NOAC? Since we know that this venous thrombosis is very possible because of the cancer. But once we treat and the cancer is under control, is it necessary to keep this NOAC, or like how long should we treat them? So and also the NCCN and ASCO guidelines in the so let's say minimal duration of the anticoagulation is about 3 months, but generally we're suggested to treat these patients about 6 months. So this 2020, the NCCN guideline update shows that if you want to treat these patients, NOAC will be a priority choice compared with low-market heparins. And about 3 to 6 months will be a choice to treat these patients. And at the same time, we have to treat the cancer very aggressively. But some new information comes out. So that's the 2021, the guideline also updates. And they also focus on the cancer-associated venous thrombosis. Also, we briefly call it like a CAT, these patients with CAT. And also, they will suggest the treatment choice, and because the evidence-based, and we can use like epizotin, idoxaban, or reversible. And the other thing is about the patient, if they are contradictory to anticoagulants. The other choice is about the IVC filter, or they can even use like mechanical thromboectomy. Like in the cast room, we can do like the angiojet or like to treat this thrombus burden. Okay, but later on, this comes more questions. Now we know we can treat NOAC with 3 to 6 months, but if the patient with a high risk to have the given thrombosis, and like how long should we keep the medicine if the patient has very high risk to do this before the treatment of cancer, like we do prophylaxis? So we need some more evidence. So the Cardio studies, they have some subgroup analysis about like if we can keep a low dose of the anticoagulation to do like prolonged treatment, will it be effective? But actually, GI bleeding is still concern. So there's 2 ongoing trials, and hopefully we can get the result like at the end of this year. And one is the EVE study, and the other is the API-CAT study. So if you use a very low dose of epizotin, it's a 2.5 milligram BID bleeding, but it also have reduced the possibility of recurrent venous thrombosis. How about prophylaxis? So we already have one result as we use the reversible 10 milligram per day and compare with the placebo in patients with a high risk of venous thrombosis. This is based on the corona risk score. Intention to treat the venous thrombosis, even it's kind of like insignificant, but declaration prophylaxis have a lower risk of the recurrent venous thrombosis. But the payoff is they has a high risk of bleeding. Okay. The other prophylaxis study is about the AVERSE study. This is use the epizotin 2.5 milligram twice daily compared with placebo, also in patients with active cancer and the high risk of venous thrombosis. And they're very interesting that we found that the effective of these prophylaxis drugs can reduce the possibility of recurrent venous thrombosis. Suggest that we can try to consider use epizotin or reversible and as a prophylaxis treatment in patients with a high risk of the cancer-associated thrombosis. And this all have been written in the guidelines. But actually, as I talked with our hematology and oncologist colleagues, and the kind of rare of this patient would be treated with anticoagulation prophylaxis because most significant cancer, which will cancer, while this patient will also have very high risk of bleeding. So I think they still have some like imbalance between the ideal situations and the real world practice. But the prophylaxis drugs and the guidelines suggest based on their risk, and we can try to use like a 4-week prophylaxis drug in the outpatient primary TE. Also, we can do the prophylaxis about 6 months is the inpatient. Okay, so after we're talking about that venous thrombosis, the other major thing is about the arterial thrombosis, because or like receiving cancer treatment, and this is a higher possibility of this patient will have atrial fibrillation. It can be due to like this cancer drugs will also induce like autonomic disorder, like ion channel dysfunction. So in this patient, once they have atrial fibrillations and based on their intravascular risk, and so we also have to consider if we have to do like recent control or rate control. The other thing that should we we treat these patients of the stroke prevention, like use the anticoagulation. So this is one circulation articles published last year. Let's talk about this issue. So once the patient have atrial fibrillations, the additional thing we have to consider how we treat the patient with atrial fibrillation is a drug-drug interaction. Since we know that anti-cancer drugs sometimes will have a similar metabolic pathways as we treat this patient with cardiovascular drugs. So I think they'll suggest if we can treat with rate control or the beta blocker, it will be kind of safe. But if you want to do resistant control, either with catheter ablation or like anti-arrhythmia drugs like amiodarone or sotalone, and we have to kind of be careful about this possible drug-drug interactions. The other things like digoxin or like dronedarone, this will be suggested to avoid the use of the drug, because the review article shows here that a lot of cancer drugs will have the similar metabolic pathway like CYP1A2, CYP2C9, and the other absorptions and will have some different kind of effect between the CD drug and also the anti-cancer drugs. Okay. But about SPAF, so even this patient, they have cancer, but we also use the cardiovascular risk score to see if we have to treat this patient with the anticoagulations. But the other major things still have to do the balance between the HAS-BLAST score. Once this case, the patient have very high risk, also have bleeding. But the choice of the drugs will be equal to most of the medicines. But if we consider about the possible drug-drug interactions, while the debilitated and idazolam, it kind of have less potentially drug-drug interactions because the different kind of conclusions. That's the cancer-associated thrombosis, the CAT, is an unignorable issue worldwide, and we have faced it every day. But early detection is still a major thing, especially in patients who has very high risk and of the cancer-associated thrombosis. So early detection, the RCT study shows that's kind of effective about its drugs compared with low-market heparins. And so we have at least treat this patient to 3 months, but 6 months would be more ideal. It will also be written in the NCCN guideline. So prophylaxis of prolonged use of medication is very possible, but I think I have to do it individually since this patient also have very high risk of bleeding. And the SPAF, stroke prevention, atrial fibrillation, is another issue, and we have to treat these patients, especially in the consideration of the possible drug-drug interactions. And much.
Dr. Chan, thank you very much for the beautiful presentation and the detailed summary of this field. Sir, I agree with that NOAC would be the beneficial for the prevention of the thrombotic events, even in cancer patients. And I have only one simple questions. I think that NOAC is a very important medication, but bleeding should be considered critical complication even in NOAC patients. So how can I stratify the risk of bleeding for patients using the NOAC in cancer patients? Also, the HAS-BLAST is good, but the cancer itself is a bleeding risk, and moreover, the cancer patients has multiple and very complicated comorbidities. So that's how do you identify the high risk patients for bleeding?
This is a very nice and important question, because we know that if we treat with patients either with like atrial fibrillation, for example, and we use the trauma score and the HAS-BLAST score, but there's a lot of overlap between these two scores. And so like the cancer thrombosis, we use the corona score, but one thing is about this, is a patient have anemia or like a leukocytosis, there will be 1 point of the corona score. But it has like a similar phenomenon, because these patients also have a high risk of a HAS-BLAST score. So I think it's always the dynamic between as we treat these patients, not if the patient have cancer or without cancers. So I think about these patients, especially the corona score that shows that a patient, if they have GI or GU tract cancers, they are especially at high risk of bleeding, especially GI bleedings. So I think they still have a very difficult situation that's like how to treat these patients. So if the patient is not tolerable to the anticoagulations, the other possibility we can do the IVC filter and the other mechanical device to prevent the thrombosis, especially going to the embolism. But about the anticoagulants, I think aggressively treat the cancer to avoid the possibility of a cancer thrombosis, and we can treat the anticoagulation with a short duration, like 6 to even 3 months. And I think if we can suppress the activity of cancer, and later on, because the cancer currently will be possibly be cured, so I think it's very possible that we can can use like a low dose of like NOAC, like we are to ongoing trials. So I think if we can treat with low dose, and maybe we can reduce the possibility of bleeding. But about your question, I think it's still very difficult to judge. If the patient have a high risk of thrombosis, they also have a high risk of bleeding. Yeah.
Okay. So anyway, the careful observation is required. Okay.
Yeah.
Okay. Are there
I think,
any questions or?
NOAC is quite interesting, but some our patients cannot afford the NOAC. So, do you recommend the warfarin or
Yeah.
any medication?
Yes, okay. So, but I think the one thing about the warfarin is that it's kind of difficult to judge that the effect of warfarin because we can measure PTNR, but we know that the Asia population, sometimes our PTNR should not be 50, in like 2 or 3 times, because I know like Japan, sometimes they will use like a 1.5 to 2.5, so I think the Coumadin's and if the patient cannot afford the NOAC will be a choice, but like what kind of dose or what kind of duration should we treat with warfarin? Actually, we have no evidence because in the past, most of the trials they just use Coumadin as like a replacement of low-mercury heparin, but it's not very we don't have many experience about the evidence to show that is the Coumadin will be also effective in this patient. Yeah.
Okay, thank you. Are there any questions or comments? Okay, so we're already behind the schedule. So could you please move on to the next speaker?
Yeah, thank you. The next topic will be presented by Professor Mongkon Usini Surebata from Mongolia. He is the chief of cardiac rhythmology center, National Cardiovascular Center, First State Central Hospital, Ulaanbaatar, Mongolia. He will address the topic of arrhythmias and QT prolongation in cancer therapy, surveillance and management treatment strategy. Please, Dr. Mongkon.
Thank you. I will share my screen. So
yes.
thank you very much, dear chairpersons and colleague speakers and dear viewers worldwide. Good afternoon. It's my great pleasure to discuss about the arrhythmia and QT prolongation in cancer therapy and surveillance and management strategy of it. So I'm Dr. Mungu Ulzi, and I belong to the Cardiac Rhythmology Center of the Third State Central Hospital. And I'm from Mongolia, and this is as beautiful country as any of your countries. So I hope one day you can have a chance to visit us also. So back to our main subject. So different types of cancers and treatment against these cancers or even adjacent treatment used for these patients can actually cause a new onset of different types of arrhythmia, and also exacerbate the existing arrhythmias is also another possibility. And some studies even demonstrating that the patients with cancer, they have coexisting or pre-existing arrhythmias already in 16 to 36% of them. So why arrhythmia is a concern? Because the arrhythmia and the QT prolongation can actually lead to more severe symptoms to the patient, and even sometimes can cause life-threatening conditions such as torsade at the point. So that's why we need to pay attention to this particular subject. So in terms of arrhythmias, we can see that there can be many different types of arrhythmias that are occurring, even including supraventricular arrhythmias, ventricular arrhythmias, sinus node dysfunctions, and also different conduction abnormalities. And if you see this table, actually the cancer treatment today is employing different combination of treatment, including chemotherapies, radiotherapies, and surgeries. So these treatments targeted on prolonging and improving quality of life of the patient and possibly to actually provide cure to the patients. But many of these treatments, including these medications in medicines in the table shown, actually can cause cardiovascular complications, and that is including many different types of arrhythmias as listed in this table. So this cardiotoxicity related to anti-cancer treatment is important to recognize, as it can actually significantly impact the prognosis and the survival of the cancer patients. And due to actually increasing of the aging population and also different types of cancer treatments, it seems that the cardiologists and the oncologists in the future will be working hard together. So we can discuss a bit about some major arrhythmias that are occurring during the cancer and its treatment. First, we can discuss about supraventricular arrhythmia, and actually, it is shown that any type of supraventricular tachycardia arrhythmia is actually possible, including supraventricular tachycardias. But amongst them, it's reported that atrial fibrillation to be the most common one to be existing. And actually, this atrial fibrillation can occur due to cancer itself or the coexisting diseases or related to the cancer treatment toxicity and even adjacent treatment the patient is receiving. So some studies demonstrated also the atrial fibrillation is also occurring more frequently after the lung resection surgeries. And again, also due to the cancer itself or the medical or surgical treatment complication. So as for the treatment, we can think about the algorithms of the general atrial fibrillation treatment, where we discuss about rhythm control, rate control, and anticoagulation. And for anticoagulation therapy, we do need to be careful because the cancer itself actually can be prothrombotic or sometimes can also be increase in the bleeding risk itself. So it is still recommended that the CHA2DS2-VASc score and HAS-BLAD scores to be used. However, this CHA2DS2-VASc and HAS-BLAD scores are actually not fully validated among the cancer patients. So again, we are in a difficult condition to actually make the decision. So it is pretty much requiring careful assessment of each individual patient to initiate anticoagulation therapy. So we need to consider about the comorbidity of the patient and bleeding risk, and also the patient's personal value and preference. And if the CHA2DS2-VASc score is equal to or higher than 2, and platelet rate and platelet is above 50,000, it is still recommended to initiate anticoagulation therapy. And one of the anticoagulation therapy can be a vitamin K antagonist, warfarin. And then it is recommended that we can try to keep the time in therapeutic range to be over 70% among these patients. Also, we can use novel oral anticoagulants, although there are still needs to have major studies, but existing studies are still having some positive results. So this can also be one of our options. And for short and midterm measures, we can, this is also recommended that low molecular weight heparin can be used in this kind of patients. Then it comes to the rate control and the rhythm control. For the rate control, we can use beta blockers and calcium channel blockers as general atrial fibrillation management guidelines. And if the patient is not tolerating the two medications well, and if the patient is in a heart failure condition, sometimes we can also recommend them some dosage of the digitalis. And for rhythm control, it's actually more difficult decision to make. And for this one, we need to have a good balance whether we should have the rate control only or the rhythm control. And this definitely need to be patient-centered decision and based on their symptoms, and the patient and doctor need to have a close collaboration to discuss about this option. And for a different kind of bradycardia or the conduction blocks, the research suggesting that the individualized approach should be taken, and before we are making any permanent treatment options, we still need to identify the cause and try to fix the causes. It includes the electrolyte imbalances and trying to use the alternate treatment options for these patients to eradicate the bradycardia or the conduction blocks. So now our another major discussion topic is the QT prolongation. The causes of QT prolongation actually can be different, and the cancer itself can cause QT prolongation. Electrolyte disturbances can be existing there, and the different predisposing factors that we will mention later can also affect, and not only the cancer treatment, but also the concomitant medications that are used for this patient can interact and cause the QT prolongation. So why we are talking about QT prolongation is it actually becomes base of the life-threatening arrhythmia, and that we all know, and this is called torsade de point. But we must also understand not all QT prolongation is causing torsade de point. So when we are managing the patients with QT prolongation, we have to keep some balance how to manage this. And however, we still must not forget that each 10 millisecond increase of QT duration can contribute to 5 to 6% of increase in cardiac adverse events. So with all this in mind, every oncology patient, we need to have a proper pre-treatment assessment for each patient. That should include well-taken medical history and medication history. And not only to forget also pre-treatment ECG with a calculation of the corrected QT interval is essential. So why do we need such kind of proper pre-assessment of these patients? Actually, because this is a table, we can see that different types of medications that are used for the cancer patients, majority of them actually can cause quite significant QT prolongation, and quite some of them can actually cause QTC over 500 milliseconds, or to cause increase in QTC above 60 milliseconds compared to the baseline. And this is creating high-risk conditions for these patients. And among these among these medications, we can see this arsenic trioxide on the very bottom. Seems to be causing more significant increase of QT and demonstrated higher rate of torsade de point. So we need to pay more attention for this kind of medications. And this list of medication that I have shown is not the complete list of the medications that is affecting the QT interval. So this webpage, Credible Meds, that is also recommended by the different guidelines, it has more information about the medications that are having possibility to interact and to cause QT prolongation or QT differences. So we can access for more information to this website. And not only the treatment is affecting the QT interval, as mentioned previously, we need to perform proper pre-treatment assessment and to identify other related risk factors that can include electrolyte imbalances, and mainly due to nausea or diarrhea, or comorbidities, especially hypothyroidism and some non-correctable risk factors, including long QT, aging, and gender, and so on. So we need to take all this into account while we are managing the QT prolongation patients. So then measurement of QT interval itself, correct measurement of QT interval itself is quite important. And first, it is recommended to use lead 2 and lead V5 to do the measurement where the T waves are more visible. And we use the intersection of the T wave maximal slope with the isolinic line to find the end of the QT interval. So we can on this image we can see different types of T wave and how to do the measurement. And then, however, the direct QT measurement alone is not very helpful, but it has a variation following the heart rate. So that's why we use a QT interval corrected to the heart rate, and most commonly used formulas above mentioned two formulas, and some studies also suggesting that the Hodge formula is more accurate for the heart rates above 90 beats per minute. Then we all know normal values of QTC, corrected QT interval in men and in women. We need to put a higher concern if the QTC is above 500 milliseconds, or if there is above 60 millisecond difference compared to a pre-treatment baseline. So QTC is recommended to be checked more frequently in the beginning of the treatment and followed up periodically afterwards. But however, if the patient having diarrhea or arsenic trioxide, as we mentioned before, is more high risk medication, then actually it is recommended that we can follow up and check the QTC more frequently, even on a weekly basis. Then meanwhile, we are taking care of the patients. Actually, the patient consultation is also quite crucial, and they need to be taught of the risky signs and symptoms, including syncopes and palpitations. Then how to manage about the QT prolongation. It does consist of electrolytes to be corrected and possibly discontinue or to find alternative medications for the medication that is possibly causing QT prolongation. And if there is a torsade at the point, critical condition, then we can use magnesium sulfate as it is mentioned in the advanced cardiac life support, and we just follow this advanced cardiac life support recommendations. And sometimes if the patient is unstable, then it is also recommended that the beta-adrenergic medication, isoproterenol, to be used, or temporary pacing to be used to keep the patient's heart rate higher. And once the patient is in hospital, then the QT notification is recommended to be used to identify some risky conditions, and especially predictive and worrisome signs of torsade at the point includes the prolonged QTC and severe aberration of the TU wave, and its beat-to-beat instability, especially when the R wave, RR interval is longer than T wave, more aberrant. Also, a frequent number of VPCs. So these kind of things we should be evaluating for each patient and to identify some risky conditions for the patients. If the patient having a very severe bradycardia, then we can recommend dual chamber pacemaker for this kind of patients. And if the patient is in a high risk condition after being resuscitated from sudden cardiac death or severe arrhythmia existing and no alternative medicines, and if the patient is expected to have life expectancy of over 1 year, we can consider about implantable cardioverter defibrillators as well. So this was an interesting algorithm that been through, and this is how to monitor the QTC prolongation in cancer patients. So whenever the cancer therapy is starting, then we should have a pre-treatment assessment, including 12-lead ECG and with the calculation of QTC interval. And if it is within the normal ranges, then we start the cancer therapy and check the QTC periodically, as mentioned before. And if there is an increase in the QTC over 60 milliseconds from the baseline, then we check the other possible causes of this increase. And if there is electrolyte disturbances or medications, then we try to lower them and correct them. And if the patient is still, asymptomatic and the QTC is less than 500 milliseconds, we still continue with the cancer therapy. However, if the patient is symptomatic and over 500 milliseconds of QTC, then we actually try to reassess all the medications and try to stop the QT prolonging medications and rearranging the medications for the patient. And again, as mentioned, if the torsade point is started, then we follow the ACLS guidelines. So from this, we can see that the cancer therapy and arrhythmia risks of the patients, considering all these balances and to treat properly of these patients is actually quite a challenging task for everyone. So thank you very much.
Thank you, Professor Mangkut.
Thank you.
For excellent talk. Is there any question from the panelists? Do you have any experience with cancer treatment to develop the life-threatening arrhythmia? I myself, I have a T case of life-threatening arrhythmia caused by 5-FU. I'm not sure that anyone have any medication therapy for the cancer. Which one is the most common? Dr. Mangkut, do you have any experience?
Well, actually, in Mongolia case, now while preparing this talk, I was thinking that in Mongolia, we have an oncology center. Actually, all the oncology patients are accumulated in that center alone. And so that's why I feel that in centers like ours, like in our hospital, we are having very low experience to interact with this kind of patients, and in some ways I feel quite sad because I do not have so many challenging issues around myself related to cancer patient and arrhythmia cases. But for the oncology center, I think they have a cardiologist in that hospital working for their hospital. She might have some critical issues, but in our hospital, actually, we have very few, almost none patients that I have seen in my practice up to date.
Thank you. Any question? If we don't have any question, so I think we move to the last speaker. Please, Dr. Hiro.
Okay, so I'd like to introduce the last speaker. The last speaker is Dr. Junichi Ishida from Japan. He's an assistant professor at the Department of Cardiovascular Medicine, the University of Tokyo Hospital, Tokyo, Japan. The title of his presentation is Hypertension Surge in Cancer Therapy by Vascular Signal Pathway Inhibitors, a signal of therapeutic efficacy or a target of anti-hypertension treatment. Dr. Junichi, could you please start the presentation? Dr. Shita, please dismute.
Sorry. Okay. Thank you, Dr. Kaneko, for your introduction. Let me share my slide and let me have my face up because for the stable presentation. Is thank you for your answer. Can you see my slide?
Yeah, I can see your slide.
Okay. Oh, sorry. Okay. So I'd like to thank you for this opportunity to provide this presentation today. Signaling pathway inhibitor related hypertension. And my name is Junichi Ida from the Department of Cardiovascular Medicine and Graduate School of Medicine at the University of Tokyo. Okay, I don't have any conflict of interest. So before I start talking about hypertension caused by vascular signaling pathway inhibitors, we need to understand the importance of angiogenesis in tumor progression. This figure shows steps in tumor progression and angiogenesis. Hypoxic tumor microenvironment triggers cells to produce and release chemokines and cytokines. The overexpression of growth factors enhances protease production, leading to degradation of blood-based lamina and moderate end-cell cell migration and proliferation. The tip cell guides the sprout of new blood-based cells towards the stimulus and recruitment of neural cells and generation of new basal membrane enhance blood-based maturation. So this is tumor angiogenesis. This slide shows the concepts of angiogenic agents. Dr. Folkman is a pioneer in the field of angiogenesis study, and he was convinced that tumor angiogenesis was a necessary component of tumor growth, and the antagonism of the angiogenic process could constitute a new form of cancer therapy. And he made this clear in around 1970, which was first to use the term anti-angiogenesis to describe a potential therapeutic approach. So as tumor cells need nutrients and oxygen to grow, they secrete growth factors such as vascular end-cell growth factor, and which promote tumor angiogenesis, and administration of angiogenesis regress best cells, and finally tumor shrinks. This is a concept of anti-angiogenic agents. So we have some approved angiogenesis inhibitors shown in this figure. They are classified into two main classes, namely anti-vascular signaling pathway inhibitors and VSV inhibitors, which work extracellularly, and small molecule tyrosine kinase inhibitors, which work intracellularly. For example, bevacizumab, very famous and first clinically available VSV inhibitor, a monoclonal antibody targeted against soluble VEGF protein. It was approved by FDA in 2004 for the treatment of metastatic colon cancer. And since then, small molecule tyrosine kinase inhibitors, so-called TKIs, with a potent VEGFR inhibition, have been approved for an array of solid tumors, such as sorafenib, velafenib, and so on, shown here. And unlike antibody drugs, each TKI has a multiple molecular targets as shown here. And these 5 agents, so-called everyone TKIs, they are used for the treatment of chronic myeloid leukemia. And these 2 VEGF TKIs, so antagonist agents, sorafenib, sunitinib, are the examples. And here, the numbers represent percentage inhibition kinase activity. So, for example, these VEGF TKIs selectively inhibit VEGF receptors. And each TKI has different selectivity for its target molecules, which may create differences in therapeutic efficacy as well as different side effect profiles. This figure shows adverse effects of VSP inhibitors. VSP inhibitors showed systemic drug-induced pneumonitis and alveolar hemorrhage in respiratory in lungs. So sometimes from the viewpoint of specialists, sometimes also should be often cared by specialists. So therefore, patients receiving VSP inhibitors require a team-based approach consisting of specialists described here. From the viewpoint of cardiologists, hypertension is one of the most common side effects of VSP inhibitors, and thrombosis particularly to be noted. The left figure shows the proposed mechanism of VSP inhibitor-related hypertension. The effects are reduced VSP signaling, vascular signaling, and consequent reduction in production of vasodilators, so nitric oxides and prostaglandin vasoconstrictors, and SRIN1. And their function is caused, resulting in increased vascular tone and arterial remodeling. And the reduced pressure, natriuresis, and impaired lymphatic function contribute volume overload, and these two mechanisms induce hypertension. The right table indicates the incidence of hypertension. So all grade and grade 3 for hypertension, incidence of hypertension as shown here. So for example, all grade hypertension ranges from 50 to around 40%. So let's look at the mechanism of hypertension and the anti-tumor effect of VSP inhibitors. Of VSP promotes on the tumor progression and as well as the onset of hypertension. So in other words, it is a shared pathway. So is VSP inhibitor-related hypertension a signal of the therapeutic efficacy? The answer for this to this question is generally yes. So let's look at the actual clinical data on the next slide. This figure shows the bevacizumab-related hypertension as a prognostic marker. In this study, around 200 patients were analyzed, and the left figure and right figure shows progression-free survival and overall survival, respectively. And hypertension in both progression, PFS and OS, hypertension was associated with a better clinical benefit, and they were both significant. Let me show on the study. This figure shows the result of sorafenib-related hypertension as a prognostic marker. In this study, around 40 patients were analyzed. They are most of them are HCC patients, and as shown here, patients developing hypertension showed a better survival. So this table demonstrates evidence of VSP inhibitor-related hypertension as a prognostic marker, and the development of VSP inhibitor-related hypertension itself may be a strong prognostic marker. although initially debated as a clinical experience with VSP inhibitor therapy has grown, particularly with the expanded use of the oral TKI therapies, it has become clear that the development of VSP inhibitor related hypertension is associated with better survival. Although some studies did not show significant clinical benefit in patients developing hypertension. So how is management of VSP inhibitor-related hypertension? There is currently no formal guideline on the type of blood pressure monitoring in patients VSP inhibitor therapy. But based on sometimes profound blood pressure rise, frequent, for example, daily blood pressure measurement might be required, and baseline measurement is also mandatory. VSP-related hypertension can be managed by common antihypertensive medications according to the treatment guidelines for hypertension. And based on the patient's general condition and the coexisting disease, such as heart failure, chronic heart disease, or coronary artery disease, antihypertensive drugs can be determined. And targeted blood pressure is usually set around 130 over 80 milligram Hg, but it's not clearly defined in this population. But it remains also unclear how TKI-related or VSP inhibitor-related hypertension is managed in daily practice. It is noted that when poorly controlled hypertension can cause cardiovascular events. So in conclusions, anti-angiogenic inhibitors VSP inhibitors cause various systemic complications besides anti-tumor properties. And hypertension is one of the common side effects in cancer patients treated with anti-angiogenic inhibitors. And VSP inhibitor-related hypertension might be associated with a better clinical benefit, and it is supported that VSP-related hypertension should be appropriately managed with antihypertensives for the prevention of cardiovascular events. Thank you for your attention.
So, Dr. Ishito, thank you very much for a nice presentation and educational talks. Because increased blood pressure, hypertension is a very common complication in patients that one question. Okay. When, for example, if you prescribe the VSP inhibitors for patient with cancer and hypertension, do you add the antihypertensive medications before starting the VSP inhibitors to stabilize the blood pressure?
Oh, that's very good question, and it depends on baseline and blood pressure probably. So, for example, when a patient with hypertension, in a patient with hypertension, blood pressure is very controlled. Probably I can monitor blood pressure, and after the blood pressure rise is defined, I will prescribe antihypertensives additionally.
Okay, what is your first line drugs for the before starting the VSP inhibitors, calcium channel blockers, beta blockers, RAS inhibitors, and so on?
As probably there is no formal guidelines, but calcium channel blockers can be easily used. Understand easy or
promising.
Yeah, and almost all patients calcium channel blockers can be used. But for example, patients with chronic kidney disease, RAS inhibitors can be used. So it depends on comorbidity and general condition of the patient.
Thank you very much. So, Dr. Sean, could you please comment or question?
Yes, thank you, Dr. Ishida, for the very interesting talk. I was curious with regards to your readings around the topic. Have there been any oncology studies where they have basically tried to harness that effect? You know, maybe they've put the patient on a TKI or a VEGF inhibitor and then did not actually notice hypertension. Have there been any oncology studies that have then used that to then push the patient onto second-line therapy sooner rather than later? Given that if they didn't develop hypertension, as per the studies you reported, perhaps there is an association with poorer response to the therapy?
It's a very difficult point, and patients with multiple after the administration of a multiple regimen, the patient condition is get how can I say, anyway, in patients with advanced or difficult to cure stage, antihypertensive selection of antihypertensive is can be difficult, I think.
Yeah, I mean, I acknowledge that it might be sort of putting you on the spot a little bit, maybe bit more of an oncology type question, but I was just thinking in terms of, you know, hepatocellular carcinoma, where we actually have, you know, large Asia Pacific registries, given that it's quite endemic, you know, hepatitis is quite endemic in this region. There is probably an opportunity there to harness that clinical effect, because sorafenib is a lot cheaper than other kind of therapies for hepatocellular carcinoma. And I wondered if there are any clinical studies that are going on or have been published, or in the future perhaps, where, you know, patients are trialed on sorafenib, but if they declare themselves to be not developing hypertension, then we can harness that quickly to then move them on to other more you know, expensive therapies like you know, radioisotope therapy, where they insert, you know, kind of radioactive spheres into the hepatocellular carcinoma itself. But it would help to save time if we had like a clinical indicator as simple as hypertension, as to whether the patient was going to respond to the sorafenib or not.
Sorry, I'm sure. I'm very sorry.
Yeah, that was fine, but very interesting. Thank you so much for the studies. Thank you.
Yeah, are there any comments or questions? Professor Surima Hacho, do you have any questions or comments?
No, I have question like you comment first. Yeah, I question about the which one is the antihypertensive of choice. So I think calcium channel blocker is maybe the good one. Yeah, I think.
Okay. So then, may I close this session or?
Yeah, maybe you can close the session. Yeah.
Okay, thank you very much. So I'd like to close this session. I thank the chairperson and speakers and our audience to give me such a good opportunity to participate in this education session. As everyone in this session knows, oncology is an emerging field, but currently this field is very important for not only cardiologists, but also oncologists. And so I believe that this session would become educational and helpful for the audience and the discussants and the speakers to improve clinical practice for patients with cancer and cardiovascular disease. So once again, thank you very much for this opportunity. Goodbye.
Bye.
Yeah, bye.
Bye.